Hello everyone and welcome to CRAMSURG, Clinical Research Appraisal and Methodology for Surgical Trainees, where we pick a paper fresh from the press on a hot general surgical topic. We review it for you, we present it for you, we critique its methodology for you, and provide top-of-the-field expert opinions and teaching on research appraisal and methodology. My name is Gio Perrin, and together with Professor Saba Balasubramanian, Adam Haig, Ben Wood and Josh Lau, we bring you CRAMSURG from the wonderful region of the Yorkshire and the Humber.
In this tutorial, we're going to be talking about what bias is in the context of observational studies. And we're going to talk about two kinds of bias, stage migration and immortal time bias. And this will be particularly of interest to people in the cancer field, because these two phenomena relate a lot to cancer research. And I'm going to choose examples from upper GI and colorectal surgery. So if there are any GI trainees, hopefully this will capture their imagination. Right. So let's just talk about what observational studies are. So there's a separate tutorial on observational studies and study designs, and that's on YouTube. So you might want to have a quick look at that. And I'm going to provide a very brief running summary of what observational studies are. So essentially, these are studies that do not necessarily aim to evaluate an intervention and do not intervene in the natural history of the disease. So these are just observational processes. So just to look at some examples, what kind of questions are potentially answerable with an observational design? Some examples in the field of thyroid surgery are some research questions as examples are, what is the prognosis of low-risk thyroid cancer? So that's going to be an observational study. You build a big database of thyroid cancer patients, identify the ones that are classified as low risk based on whatever criteria, pick out some prognostic factors you want to study, and just run over time to see whether you can use those prognostic factors to relate to clinical outcomes. Another question could be, what are the outcomes of patients undergoing hemi versus total thyroidectomy? Now you could say, is this really observational? It depends on the context and the setting. If you're going to run a randomized controlled trial and randomly allocate some patients to a hemi and some patients to a total, that's not an observational study. However, if you're going to compare two cohorts of patients, maybe from different hospitals, one of whom usually has a hemithyroidectomy as per their standard practice, and another group undergoes total thyroidectomy because that's a practice in that other center, then you can compare the outcomes in these two groups, and you can still call that an observational study, because you haven't intervened in what is naturally going to happen to those patients. You're simply collecting data on patients that are undergoing different treatments. So if you want to understand patients' attitudes and perceptions of radioiodine treatment, for example, that would be an observational study, because you're not changing practice with regards to radioiodine, you're simply observing their perceptions. If you wanted to look at the role of ultrasound and cytology in thyroid cancer diagnosis, again, this could be observational if you are not doing more ultrasound scans or doing more cytology and simply looking at what is already being done. So I hope that clarifies what observational studies are. So essentially, they evaluate the relationship between different variables. Now, in most observational studies, there is a variable called or categorized as exposure, and there's another variable that you could call an endpoint. Now, in some studies where you're looking at a risk factor and the occurrence of disease, the risk factor is the exposure and the occurrence of disease is the endpoint, like, for example, tobacco smoking and lung cancer. In some other kinds of observational studies, you have treatments, and you want to evaluate the relationship of the treatment with the specific outcomes such as survival or recurrence. So here the treatment is the exposure, and the clinical outcome, which could be survival or recurrence, is the endpoint. Right, so three main types of observational studies. Again, very briefly, you've got the case control group of studies where you start off with the endpoint, and then you look back to see whether exposures occurred. So you start off with healthy people and people with the disease, and then you look to see what kind of exposure they've had to the risk factor in each of these two groups. The second type of observational studies are the cohort studies, where you don't start with the endpoint, you start with the exposure to either the risk factor or the treatment. And then over time, you look to see if the endpoint has occurred or the outcome has occurred. And so these are cohort studies. And the third main group of observational studies is what we call cross-sectional studies, where you evaluate both the endpoint and the exposure together at any point in time. There are some other kinds of observational studies that we won't go into any detail now, and these are ecological studies and proportional mortality studies, but they're not really, they don't fall within the scope of this talk. Right, so we've learned what observational studies are, or we've had a quick revision, and now we move on to what bias is. So bias is something that systematically deviates the results of a study from the truth. The word systematic is key, as opposed to error, which is simply a mistake that is random, that is not systematic. So it could be an act of commission or omission. Now let's just look at an example. So let's say we are looking at a trial that's comparing laparoscopic versus open colorectal surgery in an acute setting, akin to the trial that we just discussed. A bias in the conduct of this trial could be something like you include surgeons with very little laparoscopic experience and then randomize patients who need either open or laparoscopic surgery to those surgeons. So they'll obviously be adept at doing open surgery, but maybe not so much with laparoscopic surgery, and therefore you're introducing bias. That's one example. It could be that you have surgeons who are recruiting patients who know what is going to come next in the random sequence. So if they have a prejudice against a specific treatment, that might bias their recruitment, and it might lead to what you call selection bias. It could be that there's a high rate of protocol deviation or dropouts. Let's say, for example, you randomize quite a few patients to open surgery, and they then, after randomization, before being wheeled into theater, have expressed a clear wish to have laparoscopic surgery. And if this happens very frequently, that's going to significantly bias your results. So that's another example of bias. How about errors in these kinds of studies? Errors are, like I say, very random, simple mistakes, maybe sometimes not so simple, but examples are things like you have included a patient who actually did not meet all your eligibility criteria, and that was a mistake. And you or the researcher has made some errors in transcribing what's in the operation note into the data collection form. That could be a mistake. If you've got the incorrect date of discharge, for example, instead of 11 days in hospital, you've got 1 day in hospital. And if you're comparing length of stay in the two groups, then that's a mistake. So I hope this clearly explains the difference between bias and error. Now, when we say error in this context, this is different to the errors we talk about in clinical research, and where we categorize results of the study in testing a null hypothesis. And if you have errors there, you call them type 1 and type 2 errors. Those errors are relevant in another context, and not doesn't relate to the type of errors that we've just discussed. Okay, so I'm hoping that makes sense. Now, you've got to keep in mind that bias can occur at any stage in a trial. So from the planning stage, conduct, analysis, and reporting, you can have bias at any point in time. Now, I've got a few examples of bias at each stage of a study, and these are all on the screen here. Now, I'm not going to go into too much detail into all of these biases, and these are just examples of numerous types of biases that can take place in every part of the study. So, just a few examples. So, if you look at flawed study design, so if you've got a study design that's probably a case control study, which may not be appropriate for a study that which really wants to estimate risk of a particular outcome from a risk factor. You want to get a good estimate of risk. You really need relative risk, and a case control study is not suited to give you relative risk. Then you've got a design flaw right at the start. Yeah. So if, for example, detection bias. So if there is a problem with diagnosing a condition on an imaging study, and you do not ensure that the radiologists who are interpreting the images have a clear understanding of the requirements of the study, and you don't validate the radiologist's interpretation, then you've got a problem. That's detection bias. An example for bias during analysis would be a grouping bias. That's a good example. So we've previously discussed the principles of analysis in randomized controlled trials. We've talked about intention to treat analysis and per protocol analysis. And in intention to treat analysis, you analyze the patients according to the arm that they were randomized to, regardless of whether they got that treatment. And if you don't do it that way, you'll have a grouping bias. You would have put the patient in the group that you were intending to, and that'll be a problem. And in reporting, you can have something called publication bias. You all probably know that studies that have negative results or results that are not very exciting struggle to get published, and they don't come into the limelight. And more studies of those kinds may be done. And then if you're doing a meta-analysis and you're looking for all studies in a particular area, and you're basing your retrieval of studies based on what is published, then you might not get the studies that haven't made it into print because they had negative results. So that could bias the results of your meta-analysis. Okay. So much for bias and the types of bias. And now we're going to discuss a specific kind of bias called the stage migration bias. So what does this mean? So here's an interesting quote. And you probably haven't heard of Will Rogers. Will Rogers was an American comedian from the early 20th century. And one day, I think on stage, he said, when the Okies left Oklahoma and moved to California, to raise the average intelligence level in both states. A bit of an awkward statement to make in front of people who were probably from both Oklahoma and California. Now, if you think about this statement a little bit and say, how can this happen? How can movement of people from one state to another raise the average IQ in both states? The only way this can happen is if you move a cohort that is below average in its current location, i.e. Oklahoma, to a location where their IQ is above average in the new location. So you might have to think about this. If you're watching this in video format, you might have to pause the video and have a little think to see if this makes sense. And then you're starting to wonder, what is he on about? Well, how does this relate to clinical research? And hopefully the next two slides will explain that. Right. Let's consider the example of gastric cancer. And I don't know if you're aware that for decades there has been this perception that gastric cancer patients in Japan do much better than their counterparts in the Western world. There have been lots of studies from the US and Germany that have shown survival rates that are much inferior to the reports from Japan. And people for ages have wondered about why this is the case. So there's consistent difference in survival between a series of gastric cancer patients in Japan compared to the Western world. And a number of reasons have been postulated. The surgeons in Japan have been saying that it's the surgery that they do, the extent of dissection, D2, D3 dissection, and that's what improves the survival. People in the West have commented on genetic differences and phenotypic differences. People have commented that the average BMI in Japan for the average patient is much lower than people in the West, and therefore radical surgery is quite difficult to do. People have also commented on the use of aggressive adjuvant treatment in Japan compared to the US. And the debate has gone on and is still going on to a certain extent. So what then researchers did was they categorized the cohorts of gastric cancer patients in Japan by stage, and then they compared their prognosis. So you categorize patients in Japan into stage 1, 2, 3, and 4. I won't go into the details of the stages. I presume a lot of you will know that stage 1 and 2 relate to the extent of disease within the wall of the stomach. Stage 2, 3 relates to lymph nodes, lymph nodal involvement, and stage 4 relates to distant disease. Now, I don't know much about gastric cancer myself, but this is a general rule for most solid cancer. So stage for stage, when they looked at the survival between Japanese cancer patients and American patients, they found here that stage for stage, the Japanese patients fared better. And when they looked at the prognosis and survival of patients in the surgical cohorts, like patients who underwent surgery, and kept the non-surgical patients apart and analyzed them separately, they found again that the survival of surgical patients and the non-surgical patients was better in Japan compared to the West. So what's happening? If you closely examine and try and understand the context and the practices in Japan and the US, both in terms of getting to the diagnosis and the investigations they have in the management pathways, you'll find a number of significant differences. There are differences in presentation. Gastric cancer is much more common in Japan. They do aggressive screening via endoscopy. They're looking for in situ tumors and pre-invasive tumors. They do a number of investigations generally, even in symptomatic patients, in terms of looking for spread of disease. There's obviously differences in the extent of surgery, and for people who are probably not very familiar with gastric cancer surgery, a bit like me, this refers to the amount of lymph nodal dissection that people in Japan tend to do compared to their Western counterparts. They do a much more radical lymph nodal dissection, amongst others. So lots of differences between the Japanese management, diagnostic and management strategies and that in the West. And what this leads to is a migration of patients down the stages. What does this mean? Let's look at this in a bit more detail. So you've got these different stages of gastric cancer patients in Japan and in the US, and they obviously are drawn from the community in Japan and from the community in the US. Now, if you employ a screening strategy looking for gastric cancer in asymptomatic healthy individuals who might be at risk, then what you're doing effectively is bringing some patients from the community into stage 1. If you then aggressively image them and you have slightly different classification systems, you might be pulling some otherwise stage 1 patients who might be stage 1 in the West to stage 2, because you're looking for tumor infiltration across the wall a bit more closely, you're doing endoscopic ultrasounds and so on and so forth. And this is where it all started, the endoscopic ultrasound and so on in the 70s and 80s in Japan. If you do then more extensive surgery in your so-called stage 2 patients, and you're doing D2 and D3 dissections and looking for tiny specks of a tumor in lymph nodes or lymph node micrometastasis, the moment you have a metastasis in a lymph node, you're moving patients to stage 3. And if you follow the logic, the more investigations you do, the more you're likely to upstage patients from 1 to 4, 2 to 4, 3 to 4, because if you do whole body CT scans, PET scans, radionuclide scans, and bone biopsies looking for cancer, you will find some patients in stage 1, 2, and 3 that you will then recategorize as stage 4. So I hope you've been following what I'm saying. So what I'm saying effectively is that there is a migration of the cohorts down the stages, and this migration of cohorts, or moving patients from the general population to stage 1 to stage 2, stage 2 to stage 3, and so on and so forth, improves the prognosis of each of these cohorts compared to the Americans, who do not necessarily adopt these aggressive strategies. And therefore, these comparisons are flawed. And you shouldn't really be claiming that the treatment in Japan is better, because this comparison is subject to what we call stage migration bias. So I hope this explanation of stage migration bias is adequate, because this is quite a common phenomenon, affects not just gastric cancer, but lots of other cancers and also other diseases. And there's a link to a paper here that explains stage migration bias from the context of lung cancer. It was first described in the New England Journal of Medicine a few decades ago. And it's a good read if you're interested. So keep in mind that stage migration bias can occur in a variety of scenarios, primarily affects observational research, observational studies. And the potential solutions are essentially an awareness of this phenomenon, awareness of stage migration, and also the need for you to understand the population in which these studies are done and the setting, including the screening practices, the diagnostic practices, the investigations usually employed and how they can be different, and the treatment pathways. Okay, so we'll move on to another kind of bias that I think is quite interesting and is useful to keep in mind. This is what we call the immortal time bias or survivorship bias. Right, so in a study that compares different cohorts, the outcome of interest does not occur in a cohort for a specific time period. So this is what you need for survivorship bias to occur. I mean, this statement by itself may not make much sense, but hopefully an example will. So if you want to compare, let's say, cardiac bypass versus best medical treatment for a group of patients who, say, present with severe angina over a period of 2 to 3 years in a tertiary hospital like Sheffield, and you want to do a retrospective cohort study, then you have a group of patients who've had a bypass for angina, and you have a group of patients that have had best medical treatment. And let's say you find that cardiac bypass patients perform better. Now, this could well be because cardiac bypass is much more effective than best medical treatment. However, there's another potential reason, and this might appear quite logical as I explained. So the surgical group has probably survived the initial period after angina and are probably fitter, because unless the patient has survived the angina and then be listed put on a semi-urgent list and then had a bypass, and they've survived the time leading up to the bypass, they're not going to have the bypass. In other words, the surgical group could not have died early in the management pathway. In other words, they had to be immortal. That's the reason for the name immortal time bias. They've had to be immortal in the early period to end up having an operation. And the early deaths, the deaths that have probably occurred within the first few days or weeks, would have been classed as having best medical treatment in an observational study. And therefore, the best medical treatment will have quite a few patients who really are in the poor prognostic category. And therefore, this is not a fair comparison. And you should be very cautious about saying, oh, surgery is clearly more effective in these kinds of observational studies. Okay, so you're probably not very interested if you're a general surgical trainee in the example I've given you. So let's look at an example from colorectal cancer. So this is a survival curve, a set of survival curves. We've not talked about survival curves before, but hopefully we will do soon. So bear with me while I explain this curve. They do say a picture's worth 1,000 words, and this is a really interesting picture that gives a lot of information. So this survival curve gives you, there are 4 curves. These are all Kaplan-Meier curves. And you can see that the overall survival of patients with colorectal cancer is indicated by this solid, maybe purple line. Patients who have stage 3 colorectal cancer and who have not undergone liver resection, obviously stage 3 patients don't, their survival is shown by this dashed blue line, slightly dark. The survival of patients who've had stage 4 disease and not had liver resection is shown by this line here, as I'm pointing out. And the survival of patients who have stage 4 disease and liver mets and have had a liver resection is shown by this line here, the faint dashed blue line. Now, clearly, stage 4 patients are performing badly. But why are stage 4 patients who've had a liver resection doing better than stage 3 and the overall group? That's odd. So it's clearly very, very likely that the stage 4 patients who are undergoing a liver resection are probably the fitter of the lot, and they're able to sustain liver resection surgery, and there could be bias, the immortal time bias at play here. Now, if you talk to hepatobiliary pancreatic surgeons, liver surgeons, they're all very keen on saying doing liver resections for colorectal liver metastasis, on the presumption that resection of colorectal liver metastasis improves survival. But this is from observational studies. There is no randomized controlled trial evidence, to my knowledge, that colorectal liver resection improves the survival of these patients. So you've got to take this observational study data with a pinch of salt. You've got to think about whether immortal time bias could be at play here. But the other very interesting observation with this in this figure, to those with a keen eye, is you might have observed that the three survival curves here of patients who've not had liver resections has an early dip and carries on and then plateaus. However, the patients who have had liver resection, they are plateauing first and then are dipping later. That itself is evidence that these are fitter patients, because for most cancer survival curves, or survival curves for patients with cancer, there's often or almost always an early dip, indicating that some patients have aggressive disease and succumb from the disease, and then you have a plateau. So this curve for liver resection is quite artificial, and therefore you have to assume that immortal time bias is at play here. And again, if you're really interested, there's a very interesting article in an epidemiology journal explaining this concept in a lot of detail. Right. So what have we learned today? We've talked about bias, the types of bias, and the fact that bias can occur anywhere along the path of a clinical study. And just keep in mind that bias is systematic while error is random. And like I said, bias can occur at any stage of the study. We've then talked about stage migration phenomenon, or some people call it the Will Rogers phenomenon, after the comedian that first talked about it. And this is important in epidemiological studies, primarily on cancer. And then we've talked about immortal time bias or survivorship bias. And just think of the role of treatment pathways and how patients get onto specific treatments when you're comparing different treatments, especially surgery versus non-surgical treatment.
Thank you everyone for tuning in and listening. Until next time, keep running your life with our surgical podcast.